All right. Well, I think we should go ahead and get started. Others will join as they're able, but hello and welcome to all of you. We're really delighted you could join us today to explore the ways that the PACT process maps can support the advancement of your communication and resolution or reconciliation programs. My name is Melissa Parkerton. I serve as both the director of the Pathway to Accountability, Compassion, and Transparency, what we call PACT, and as the deputy director of the Collaborative for Accountability and Improvement that partnered with Ariadne Labs and the Institute for Healthcare Improvement, IHI, to form PACT. Our goal today is to share one of the tools that we've created for PACT, our PACT process maps, that we really think will be of use to anyone who is working to advance your CRPs. I'm joined today by Dr. Lauga Sokol-Hessner. Dr. Sokol-Hessner is a practicing clinician, educator, researcher, innovator, and leader in patient safety and quality improvement. He's a professor at the University of Washington, where he also serves as the associate director of the Collaborative for Accountability and Improvement, and as core faculty for PACT. You may have seen him previously teaching in the Harvard Medical School Masters in Healthcare Quality and Safety, or in numerous programs of the Institute for Healthcare Improvement. Lauga, over to you.
Thanks so much, Melissa. And yeah, thanks for everyone joining today. We're going to have an interactive day together. I want to start with a case that I think hopefully is not too familiar to many of you, but might be for those that are engaged with healthcare these days. Imagine Miss Smith was admitted to your hospital several days ago with an acute medical condition. This afternoon, her family's visiting, and she tells them that she's starting to feel worse. Her clinical team tries to figure out what's going on as she gets sicker. They start some treatments, they send off some tests. In the middle of all of it, a clinician says, hey, wait, did anybody see this test result that we collected earlier today? And it turns out no one had yet reviewed the results. Soon after, another clinician says, hey, wait, don't give that medication. We didn't want to do that. She quickly is getting sicker, her blood pressure dropping, and soon someone's telling her family that she needs to get moved to the intensive care unit. Within a few minutes, she's whisked away to the ICU, leaving her room quiet and everyone wondering what just happened. Did something go wrong? Is that why she's now in the ICU? As we know, cases like this, when patients appear to maybe have been harmed by their healthcare, are common. So recent estimates estimate 1 in 4 hospitalized patients, 1 in 14 outpatients experience an adverse event every year. And the impacts from such events can be severe and long-lasting. We know physical impacts for sure, but there are also non-physical impacts, the emotional, psychological, socio-behavioral, financial impacts, effects on people's relationships and livelihoods, their healthcare seeking behaviors. And while patients are primarily affected, families and the clinicians involved in such events can also suffer when these things happen. So overall, harm from healthcare is prevalent and significant. So I want to ask you all a question. We're going to use something called Slido today. Some of you might be familiar with it. For those that aren't, the way it works is you take your friendly mobile device, whether it's a phone or iPad or whatever, and scan that QR code there on the screen. And then you can go ahead and vote. And we'll have a couple of these today. Each time the poll will update on its own. If you've scanned the QR code once, you shouldn't have to scan it again. If you don't have a mobile device with you, or if you're watching today on a mobile device, you can also go to the internet. Just go to slido.com and then enter that 7-digit code there, the 3685585. And then again, you'll have joined the poll and it should update between questions. So I see a bunch of folks are voting, which is awesome. We'll hope a few more folks chime in. Really want to get a sense of where we are today as an audience, where you're all coming from, what your experience is, as we try and learn about how we can do better when we respond after harm. So this is really helpful. Got a bunch of folks voting. We see most folks here have helped manage the aftermath of at least one serious harm event. And a significant proportion, 30%, have had someone close to them experience harm from their healthcare. So unfortunately, the statistics that I cited are similar in our room today here too. We are reflecting the larger picture of harm from healthcare being something that's pretty common, actually. So thanks for sharing that. There'll be some future polls. Really want to get a sense of where you are as we talk through our situation today and how we can do a better job. So I want to start by, before we get to the process maps, just doing a bit of level setting around how we respond after harm. How we respond after harm really matters. We'll talk a little bit about the data behind that. But I want to juxtapose the historical approaches, the way that many healthcare organizations have responded in the past and many continue to, and the more modern approach, which is really the CRP approach. So historical approaches, commonly known as deny and defend, that's the terminology that's used. Whereas the modern approach is really communication and resolution programs, or CRPs. Deny and defend approaches really are organization and risk focused. They're about trying to avoid liability, whereas CRPs are really a patient, family, and clinician focused approach, trying to do the right thing by those people, trying to make care safer and improve. Historical approaches are really reactive. Rather than taking a proactive approach, they're about waiting until the patient or family ask for something or file a claim or suit in general. And that really can neglect the needs of the people who are involved in such events, whereas CRPs are much more proactive, trying to attend to the needs of people through accountability, compassion, and transparency as guiding principles. Turns out that these historical approaches, although somewhat risk focused, actually may promote claims and litigation. They may make them more likely by not meeting patient family needs for information and support. That can drive them to file a claim or litigation, whereas CRPs are actually designed to decrease that driver of claims and litigation. And I'll share a little bit of data later and some links for those that are interested. But the short of the long is CRPs do not increase claims or litigation, and in some situations might even decrease them. So they're really a better approach there too. Lastly, I think these historical approaches really limit dialogue, right? They're about not talking about what's happened. And that can impair healing, learning, improvement, and a culture of safety, really things that matter to all of us. Whereas this modern approach really is about promoting understanding, learning, and engagement. It's really much better aligned with the clinical and quality mission of healthcare organizations and a culture of safety. So that all sounds great. It turns out the evidence really supports this. I won't belabor it too much. There's some links at the bottom for those that are interested. We at CAI have an evidence compendium about CRPs that you can have a look at. And earlier this year published a AHRQ funded literature review about CRPs. The short of the long is they themselves are a patient safety intervention. Even though CRPs are invoked after someone has been harmed by their healthcare, they can prevent secondary harm. They prevent the compounding of harm that happens when we don't respond well. And that can lead to better outcomes for patients, families, clinicians, and organizations. And as a result, CRPs are really promoted by a number of leading patient safety entities, including CMS. I suspect those of you from the US who are here today are familiar with the CMS Patient Safety Structural Measure, and you'll recognize that in Domain 4, which is about transparency and accountability, there are 2 items that are about CRPs. So really, this is the better way to be doing things. It's the right way to be doing things. And so what I want to talk with you about today is we just covered sort of what is a CRP and why is it important to have one. But I want to touch a bit on the processes. We're going to talk about our process maps, which is one of the real important tools, I think, as we try and improve the way we respond and why that's pretty central to the process. And then we'll talk about some challenges of implementation and how PACT can help. So let's dive in a little bit and talk about comprehensive and reliable processes. So I'm curious, for those of you that are part of a healthcare organization, how do you feel about your organization's processes for responding after patients are harmed by care? This is an anonymous poll, so no worries. Please answer honestly here. We can use these, Slido uses these funny little emoji faces here, but the heart eyes is great. The crying eyes is not so great. Where are you falling on this spectrum? How do you feel about the way your organization responds? And if you're not primarily based at an organization, but you get your healthcare somewhere, you could respond about how you think that organization's doing with how it responds after harm. And so thanks for voting. We'll wait for a few more to come in, but I think we're already seeing a bell curve here of sorts where most folks are somewhere in the middle, with a bit of a skew to the left, at least so far, where some folks are feeling like maybe there's some opportunity for improvement, and those in the middle are sort of a little bit neutral. It's not great, it's not terrible, but maybe there's some room for improvement there. So thanks for sharing. That's really helpful. Just gives us a sense of where folks are. That's, of course, why we're here today, try and figure out how we can make these processes better. So, as Melissa mentioned at the beginning, PACT is really designed to help organizations develop a comprehensive, highly reliable process for responding when their patients are harmed by their care. Again, guided by these key principles: accountability, compassion, and transparency. And we think there are about 5 big primary drivers that help organizations get there. One of them is leadership, having good, strong leadership that believes in doing things in a different way, in a better way, and implementing those changes and supporting them and sustaining them is a really critical factor. Um, Number 2 are processes, and that's really what we're going to talk about today a little bit. The third is a measurement and learning system. It turns out that measuring how well we are responding is really critical to actually implementing better approaches and sustaining them over time, understanding where there's opportunity for improvement. And not only measuring, but then having a way to learn from that is really important. There's an ongoing need for training. Every healthcare organization these days has some turnover. So as new people come into the organization, how is it they're learning about this better way to respond? How are we bringing them up to speed? How do we make sure they have the just-in-time guidance that they need when an event happens? All of that's pretty important. And lastly, I think we found that a community of practice is really important too. This work can be challenging. It's hard. And so having a network of folks who are doing this work as well, from whom we can learn and get support, is really important. So as I mentioned, we're going to dive into this CRP processes piece and share with you one of the many tools that we have in PACT. This one, I think, being pretty central as you try and understand how your organization is doing now and where those opportunities for improvement might be. So the PACT process maps, you can actually go and get these today. They're out there on the web, free, available. You can go to ariadnelabs.org/PACT, as you see in the screenshot here of the website. And if you scroll down to the bottom, you can see a few of our tools. The driver diagram I just covered at a high level. We've got some more details in the version you can download. The process maps we'll talk about, but it's at that link there. And we can see we've got some other things, this communication tip sheet, some guidance for patients and families, and that evidence compendium that I mentioned. So I encourage you to go check that out if you haven't yet already. Um, let's talk a little bit about the process maps. If you were to download that, and I encourage you can go now if you want and download it, you'll find that it is an 8-page PDF. And I'm going to spend a little time today walking through that. At first glance, it might seem a bit overwhelming. There's a lot of information on there, but I promise we'll walk through it. And I think by the end, you'll have a better sense of which pieces of this tool might be most helpful to you and how you can deepen your knowledge when you're ready for it, how you can deepen your understanding. The guidance is all there. It starts with a page that I'll show in just a moment, but an overview. It's got a key with some definitions, and then it's got a variety of different process maps that we'll talk through. There's some simple ones, some detailed ones, and some role and phase specific ones. So before we do all that, I just want to get some sense of how familiar are you with process maps? Is this something do you regularly use process maps? Maybe you create them sometimes, or maybe this is something totally new to you. You've not really used process maps much. It's just not really been part of your work. Really helpful to just get a sense of where you are as an audience today. I'll give a moment just for a few folks to vote. Great, very helpful. So most folks here use them a little bit. There are a fair number of folks that actually teach others to create process maps, which is awesome. That's great. We would love your feedback on our maps so we can make them better. You may have some wise ideas for us. Feel free to just share those. We're always open to feedback and improvement. And then some others who are sort of in the middle there. But everyone has used a process map at some point, which is great. So thanks for sharing that. Really helpful. So let's dive in. So the first page of the process maps is really a guide to how to use them. Because again, there's a lot of information in there and you want to start with where it's going to be most helpful to you. I think the first phase is really figuring out which is the best map for you. And we've labeled the maps and we've also given them letters just to make it easier to refer to them. The basic map, which we'll spend a little bit of time on today, is map A. That's the basic overall CRP process map. The map B is the same map, but it's more detailed. It's got the roles, like who is doing which step in the process. And that's something I think that's a nuance that ends up becoming really important, but at the beginning, maybe a little bit more than you need if you're new to CRPs. And then lastly, the CRP process unfolds over about 3 different phases. We'll talk about those phases, but we have maps that are specific to each phase so that as you want to really dive down into the details, what exactly is happening in this phase, who's doing what, who's saying what are the key things that need to happen, you can see that all in the maps to help you understand how this process unfolds. There's also a key, and I'll go through this a little bit, but the shapes vary on maps. They have different meanings. I know when I started out in process maps, I just sort of thought, well, gosh, aren't they all just squares or whatever? Why are these funny shapes different here? What does that mean? And it turns out they have some meanings, so we'll talk about that. We've also numbered the main steps in the process, and those correlate between the really simpler maps and the more detailed maps so that you can easily move between them. And then there's also what we call swim lanes, which are really the roles involved in the process. I'll say swim lanes for those that are not as familiar with process maps can trip people up. They can be a little bit confusing to understand. It may take a little while to get how they work. That's totally okay. I'll try and explain them today. I'll do my best, but if they're confusing, feel free to reach out and we could chat more. And then lastly, we'll talk a little bit about the role definitions. Who are the people that are doing the work of a CRP? So as I mentioned, choosing the best map for you is important. The basic overall CRP process map, map A, is just a black and white map, so it's easy to recognize. I think it's the 3rd page in the PDF. And then, as you can see, there are more detailed maps that start to introduce colors and different swim lanes and more information about what's happening in each step. Those are really in the phase-specific maps. So we have an event detection process map, we have an early phase process map, a middle phase, and then we have 2 late phase process maps because it turns out there's a branch point. In the middle phase, we figure out whether this event we think was preventable or not. Does the event involve a claim or litigation? And if so, that changes how we talk about it. For events that end up getting referred to claims or the insurer, there's one pathway and things unfold a certain way. And for those that aren't referred, there's a different pathway. So we have separate maps for those. Before we start going through the basic process map, I want to just cover some of the shapes that are on maps so you have some sense of what they're doing and what they're about. It's not super important to remember all this, but it may be helpful for some of those that kind of wonder why is the shape different here. So the start of a process and the end of the process are these boxes that have the curved ends, the curved sides to them. That's the start and the end. Each process step tends to have a box, a rectangle, except when it's a decision point. And a decision points are key places where we have to say, okay, is this the case or is that the case? And depending on what our answer is, we branch and we may go one way or the other way. So those are diamonds and they look a little bit different. So that's the shapes. And as I mentioned, we've numbered the main process steps. So you'll see this as we go through the basic process map. You can see a little excerpt from it in the upper right here. Steps 1, 2, and 3, and 4 are all shown there. But these are the numbered process steps 1 through 12. They really are chronological in how events tend to unfold and the steps and the ways that they work. And these are really key pieces to have in your organization as you're figuring out how to develop your own CRP or improve what you may already have. So I won't belabor them here, but they're here for your reference and we can see them as we go to the basic process map. So this is the basic process map. And I'm going to zoom in just a little bit so we can see it a little bit better here. And I'll just orient you a little bit. We have the 3 phases labeled at the top there. So we have the early phase, which tends to happen in the first few days after an event. The middle phase, which happens in the subsequent weeks, ideally finishing up before 6 weeks. And then the later phase, which can take longer than 6 weeks in many cases, and depends on the nature of the event and what exactly is happening. As you can see, there are links to the phase-specific process maps under each phase title there. So it's a way when you're in the PDF, you can click and move around between the different maps if that's helpful. And then the process really begins by identifying a CRP event. So for those of you that are in patient safety and in a healthcare organization of size, For example, a hospital with 500 beds or something like that easily has thousands of safety events reported every year. Most of those are near misses or risky states or sometimes errors or mistakes that didn't reach patients. But some of them are actual harm events where something went wrong or a patient just got hurt and it was an unpreventable event. But thousands of those pings of information are coming through every year. And one of the really important things for organizations is to figure out which ones of those really need this CRP response. All events are good to respond with accountability, compassion, and transparency, but this more detailed, more involved process is really best reserved for moderate temporary harm or worse. And so, depending on which harm scale you use, your organization may define that in different ways. I will show you what we recommend as a definition for CRP events at PACT. And it's got a lot of embedded guidance in it, including a crosswalk between the different harm scales. So that's a resource for you. So that's step one. Step two is once a CRP event is identified, there's a bit of a brief intake process. The patient safety, the CRP team really needs to quickly wrap their arms around, okay, what's the event? What's happening? What's the status of the people involved? What do we know so far? That's not meant to take a long time. It's just we've got to have some basic information to begin the response process. So there's a prompt event intake. As part of that, some events from the very beginning, there might be a flag that, hey, we really need to talk with our claims and insurer folks early on this event. That tends to be events, as you can see, there's an asterisk there, and this guidance at the bottom of the process map here around which subset of events that applies to. So if it involves a claim, a pre-litigation notice, a lawsuit, if the patient or family already have legal representation, and if the event involved or if the event seemed to involve serious preventable harm, like it seems pretty clear from the get-go that we probably made a big mistake and it led to some really serious harm. All of those, that subset of events, are ones that are good to engage claims and the insurer about early. I will say that's the subset. It's not the majority of events. Most events aren't going to fall into one of those buckets. They're going to fall into something else. And you won't have to necessarily engage your claims and insurer early. But that process may also vary depending on how your organization works, how you have set things up with your claims and insurer folks. But it's an important decision point. It's a diamond. It's an important decision point in this process because if it does qualify to engage your claims and insurer folks early, you want to make sure you've done that before you go and reach out, have that initial communication, just so that it's coordinated. People know what's going to be said, how it's going to be said, who's going to be saying it, those sorts of things. So that's why that's an important decision point early. The important part in the early phase is really getting back in a timely fashion to the patient and or family, depending on whether what the patient's capacity is, to have an initial communication with them about the event. So that initial communication, it's got a few key steps. It's, hey, this thing happened, this event happened. Here's what we know so far. We're so sorry you're having this experience. This is not what we wanted for you. What questions do you have? Responding to their emotions, whatever their support needs are, saying, here's how our process works. Now, here's what's going to happen next. We're going to obviously take care of you, but we're also going to look into what happened, and we'll get back to you with what we find. And here's a point of contact for you, someone that you can be in touch with if any questions arise in the meantime. That's the basic gist of that conversation. Also, in that early phase, it's really important to be making sure that there's support being provided not only to the patient and family, but also to the clinicians involved in the event. Some clinicians, if they're involved in that communication with the patient and family, they might need coaching. They might need help. How do I say this? What do I say? Hopefully they've had some training beforehand, so it's not starting from scratch, but sometimes some just-in-time coaching can be really important. So that's a key piece. But clinicians too have support needs, emotional and logistical support needs in the aftermath of serious events. So everybody, patients, families, and clinicians need support. Those are really the key things to be getting going in that early phase of the process. As you move into the middle phase, it really transitions into the event review. There's ongoing support of patients, families, and clinicians, but really in this phase, We're focusing on what is it that happened exactly? What was the sequence of events? What do we know? By talking to people, gathering information, including the patient and family narrative, how can we learn best about what occurred and why? What were the underlying factors that contributed to this event? Through that event review process, ultimately, there's a determination of what are the things that we can be doing to improve quality and safety. And that work should always happen, no matter what. No matter what happens in the rest of this process, we're always oriented on learning and improvement. But there is also a determination by the organization as they do this review, do we think this event was preventable? Was there a deviation from the standard of care? Did we not practice the way that we should have? Did that cause harm? Or was this actually just an unfortunate event? It's unfortunately a known complication of a procedure or a medication or something like that that really wasn't preventable. Um, it's tough to say what proportion of events are preventable. If you look at the literature, it varies widely depending on the setting, but almost always it tends to be the minority of events that are felt to be preventable. There's unfortunately a lot of unpreventable harm in healthcare. So just something to think about. Um, in those cases, this is a diamond, so we're making a decision here. Was this event preventable? Did it involve a claim or litigation? Sometimes the answer is no, it wasn't preventable and it doesn't involve a claim or litigation. And then you can see it doesn't get referred to the claims insurer folks. In other situations, we say, yeah, actually, we think it was preventable and it led to serious harm. Or we say, yeah, there's a claim or litigation. In those situations, we do have to refer to the claims insurer folks. If that's the case, if we're doing that referral, then they're involved in guiding the subsequent communication that happens. That is step 7, and it's a really critical step in the CRP process. In many ways, it's what distinguishes organizations that have CRPs that are working properly from those that don't. It's this loop back to the patient and family. Often it can be weeks after the event because of good quality, high quality event review can take some time. Ideally, it's not a really long time, but we do need to have a good sense of really what happens, and we need to have made a determination about what we think in terms of preventability and next steps. That post-event review communication, the nature of it varies a little bit depending on whether we think it was preventable or not. It always involves explaining what we learned, what happened from the event, or why we think it happened, what the underlying factors were. If we think it was preventable, it involves an apology, a fault-admitting apology saying, we are so sorry that our mistake caused you harm. And in that situation, it involves a proactive referral to the claims insurer folks to conduct additional review as needed. So that's what this decision point is about. If that event is getting referred, then that claims insurer folks, they'll conduct an extra review as needed. They may collect outside records from other hospitals that the organization didn't have access to, for example. They'll assess formally that standard of care and causality, which are the two components that tend to be involved in the concept of preventability. Did we make a mistake? Did we not do what we should have? And did that mistake cause harm? If so, then the answer is yes, we think it's preventable. And then when applicable, they'll actually make a proactive offer of compensation, negotiate that with the patient and family, and manage the outcome. Now, I'll just highlight that that pathway where it gets referred and there's a proactive offer, that is definitely the minority of events. That is not most CRP events. Most CRP events don't involve that referral to the claims insurer folks. They do involve a conversation closing the loop with the patient and family. But oftentimes that can be a point of confusion in CRPs. Folks think they're all about proactive compensation in every case, and that's just not true. That's not quite how it works out. So either way, whether we referred to the claims insurer folks or not, we come back, we'll log that final outcome. So part of, as I mentioned, a reliable CRP is good measurement along the way. And so we'll log that final outcome, keep track of how things turned out so that we can report that data internally to our board. That is part of being able to attest to the CMS patient safety structural measures, being able to say, here's how the outcomes of our CRP cases, here's how things are turning out. And then steps 11 and 12 are ongoing patient family support. Just because the organization's internal CRP process might be done doesn't mean that the event and its effects are done for the patient and family. They may be dealing with this for a very long time. They may need lots of ongoing support. And then there's a need to share learning, both within the organization, a need to share what were the patient safety learnings from this event, but also learning how did we respond and how effective was our response? Could we have done better? as an organization. Sharing results with the board is a really important part of that. And ideally, organizations are also figuring out how to share their patient safety learnings beyond their organization so as to drive improvements in patient safety elsewhere, maybe through a PSO, maybe through some other learning network, and sharing their learning about how their CRP process worked. And through the PACT network, that's one way we do that. We have safe table discussions where organizations talk about how they responded, what went well, what they're thinking about doing differently next time, and sharing that learning as a community to accelerate improvements in how we respond after harm. So that's a walk through the basic process map. Questions as they're coming up for folks, anything that's coming up for you, feel free to chat it in. We'll also have a chance at the end for that, to attend to that. But that's sort of a beginner's map to how CRPs work, and hopefully is useful to those that are trying to figure out how to improve the way their organization responds. So I want to share a little bit of some of the more detailed resources that we start to provide. For those of you that already kind of know what CRP is about, that map, this map here that we just walked through, is probably sort of like, okay, yeah, I kind of knew all that stuff. For those that want to go a level deeper, that's where these more detailed process maps come in. And so I wanted to share one of those with you. This is map C, so this is the CRP event detection process map. And it's a relatively simple map, but it introduces a few features that I wanted to highlight for those that decide to spend some more time on these parts of the map. Before we go into those, I'll just highlight that at the bottom of this map, and again, in the PDF you can get off the web, you can get access to this and zoom in on it, read it a little bit easier. I know the font's small here, but that's the CRP event definition that PACT recommends. So any event that meets any of those criteria, we would say that's a CRP event, and the CRP process can be applied to that. On the left-hand side there, you can see it involves any event involving moderate or severe harm or worse. And then on the right-hand side, there are some other reasons. So if the patient or family are saying that they experience serious harm, maybe through a complaint or grievance, that's enough to qualify as an event that really would benefit from a CRP response, because clearly they have some information and support needs, even if it turns out that the harm wasn't that severe. If anybody is asking to use the CRP, or if it involves a claim, pre-litigation notice, or lawsuit, all of those can go through the CRP process. So lots of good resource there, but let's zoom in a little bit and let's talk about what these colored lines are and what these roles are on the left-hand side. So the colored rows, those are what we call swim lanes, kind of like if you were looking at a swimming pool from above and there's different lanes that go across. And the way that they work is each lane is a different role in the process. So each role has their own lane. And the five roles, sorry, that you can see listed here are patient family, clinical team, CRP team, quality, safety, and operations, and then claims, insurer, and legal. I'll define those roles a little bit more in just a moment on their own slide, but those are really the five big roles that are involved in managing a CRP process. And as you can see, each one of them has a role in helping identify CRP events. So patients and families share their experiences through complaints and grievances, often through patient relations or a patient advocate or something like that. The clinical team is charged with reporting events. So every healthcare organization has event reporting systems, and thousands of event reports are submitted every year. They play a really critical role. The CRP team may have additional methods for identifying events. They may have proactive or automated event detection systems like trigger tools or AI systems that are identifying harm events in as close to real time as possible. The quality, safety, and operations folks can also contribute. For example, when I was a medical director of patient safety, we'd sometimes hear from our external media relations department that somebody had posted something on Facebook about a harm event that had occurred, and we would get our system to respond to them to make sure that we were meeting whatever needs they had. And then lastly, claims, insurer, and legal may be notifying the CRP team about claims, pre-litigation notices, or lawsuits as they come in. So everyone has a role in identifying events. Then there's a triage process. They decide whether it qualifies or not, and then if so, it moves into the rest of the CRP process. So the other features on the map here that I'll highlight is each activity or task that a role is doing appears in their lane. So it appears in that lane because that's what they're doing. If it's not in their lane, it's not something they're necessarily doing. And the arrows that connect those lanes show how those roles coordinate and contribute to the process. At the bottom of the map, there are also links to additional tools and resources for each different phase of the process to really help organizations dive further into how this all works. So I mentioned the role definitions. I'll just go through them here in case they're not familiar. When we in PACT talk about family, we are really talking about anyone the patient wants involved in their care, regardless of whether they are legally, biologically, or otherwise related. Um, and in the CRP process, they don't have an obligation to engage in the process, but they can make important contributions if they want to, really sharing what they understood to have happened, their narrative, sharing their experience, what their information and support needs are. Um, and so they do play an important role. Clinical team really is anyone who's taking care of the patient, the sort of front line, as we sometimes say, nurses, physicians, advanced practitioners, anyone else who's involved in the clinical care. The CRP team may not be a familiar concept to some of you, but it really is the idea of that interdisciplinary team who's doing this day-to-day management of the CRP process, who's really making sure that the right things, the right steps are happening for every event as it goes along. And that's really a repurposing of the roles of folks that already exist in your organizations. You don't have to hire new people. It's really patient safety, risk management, and patient relations at a minimum. And then depending on how your organization is set up and what your environment and context are, sometimes it also includes someone from claims, the insurer, legal, maybe an executive sponsor, a program manager. A lot of folks, I think, end up finding that having a CRP program manager who kind of tracks every event, keep things on task, and can ping someone if something needs to happen, sort of a brain, and who can help with measurement there that sort of organizes the process ends up being really useful. Sometimes that's a patient safety manager who takes this on as part of their work. And then claims insurer legal, if they're not already part of the CRP team, they do have an important role. And then quality safety and operations. By that, I really mean those sort of senior organizational leaders, maybe a service line leader, the chief of cardiology, a director of a unit, a content expert like someone in the pharmacy or the IT systems who knows how something works, that's going to be part of the event review. They all have important roles as well. So I wanted to just show you how the numbers between the maps connect here. So I showed you this excerpt from the simple basic process map earlier, where steps 1, 2, 3, 4 were shown, and that's the early phase. And on the right here, you can see the early phase process map. So this is map D. We'll zoom in a little bit on that just so you can see it a little bit better here. But it is got a lot more detail. After that CRP event is identified, that's step 1. Step 2 is that prompt event intake that I described. And so here you can see this more detailed map shows you these checkboxes, sort of key things that should be happening during that part of the process. And it starts to show you the contributions from the other roles. So how did the patient family, the clinical team, quality safety operations, how do they contribute to that prompt event intake? You can see here. And then as it moves into those stages around that initial communication with the patient and family and supporting everybody involved, what are the key pieces that are involved there? So some organizations may find that helpful as they try and get a better sense of what exactly is happening in each one of these steps as we move through. I won't belabor it too much here because I know there's quite a bit of information on the map here. But that's a way to sort of dive deeper when you're ready for it. And each phase has one of these maps that you can look further into. So that's sort of the high level of the maps. And again, I welcome questions that are coming in. I haven't had a real chance to look at the chat, so I'll pause in a moment as we get closer to our time here to respond to some of those. But if you're thinking of something and it's coming up for you, please just chat it in, and I promise we'll get to it. I wanted to share with you a little bit of how PACT uses the process maps. And there are sort of two big things for this. One is that we design these to be frameworks to which you can add knowledge and skills. So as you wrap your mind around CRPs, as you get more experienced with them, it's important, I think, to have a schema in your head about how does this work? What are the steps and processes? Where do I come in? What's my role? And that's really what they're designed to do so that as you deepen your knowledge and experience, you can add to that schema, to that framework or scaffolding, if you will. We also use them as a guide throughout the PACT curriculum. So we start each learning session by highlighting, here's where we're going to be focusing today. The topics that we're going to cover are in this part of the process map, so that folks can continually refer back to that and understand how to put everything they're learning into context for the work. So that's how PACT uses the maps. What are some ways that you can use the maps? Well, one is to conduct a tabletop exercise. So if you're part of a healthcare organization, you're trying to think about how can our organization do a better job responding after harm, you can take the process map, maybe even imagining or using some of the recent serious harm events that your organization has noted, and walk through how would we respond to this event, or how could we respond if we had a CRP? What would it look like? You could take a few different events. So we've given 3 examples here you might consider. One might be a non-preventable event, and you could walk through what would this look like for us. Let's pretend we had a patient who underwent surgery and they suffered a serious complication. It was a known potential complication. It was part of the consent process, but they're still harmed. They're still injured. And they and their family have a lot of questions and some support needs. How can we as an organization use this CRP to make sure we're meeting those information and support needs, and also supporting the clinicians that were involved? How do we do that? What would that look like? So you could take that recent real event in your organization and walk through the map and say, here's what this step would be. Who would do that? What could that look like? Why might that be helpful? Etc. And kind of walk through. Another one would be to pick a recent preventable serious harm event, something where we really, we made a mistake and it caused serious harm. What would that look like if we were to walk through that as an organization? And lastly, what if it involved a claim or litigation? How would that change things? So that's one way you can use the maps. Um, Two is really to flag those maps for where you think you need some improvement work. So as you walk through an event with the map, you may say, okay, well, this parts of the process we do pretty well at. We've got a system, we've got a process, we've got people who are ready to do that. But this other part, we need some more work there. Let's put an asterisk on that as an area where we want to be doing some more targeted improvement work. Let's think about what would take, what sort of team do we need to do that work. You can also, we encourage you to customize the maps for your context. So if you're part of PACT, you get versions of these maps where you can really move things around and say, hey, this is how it works for our organization, or here's how we want it to be different. And then I think you can really use those maps as an educational orientation tool in your organization for any CRP team member. How do they get up to speed? As someone new comes on the team, how do they learn how this process is supposed to work? The process maps can really be a helpful step. As they're beginning to work through cases themselves, they can say, okay, here's where we are in the process. Here's what the next step is for that event, because here's what the map shows. So maybe a useful tool for you as you go forward. So that's our sort of going through the process maps. I wanted to spend a little bit of time talking about challenges of implementation and how PACT can help. But before I do that, I just want to check in on the chat here. I think there's one question I saw from earlier, which was, can we address the scope of harm? Many organizations do not recognize emotional harm as harm. Kathleen, I think, wrote that. Thank you, Kathleen. I couldn't agree more. It's something I've thought about a lot in my work, and I'm happy to share some more references and resources for you. But yeah, I think you're right. Many organizations do not recognize emotional harm as harm. And yet, when you talk with patients and families, or if you imagine your own experience, the emotional impact from when things don't go well in healthcare can be really serious, and can maybe even last a lot longer than the physical impacts do. Some people are still recalling events that happened decades earlier because the way the organization responded really stuck with them and was not a good response. So I think it's a really important thing. It is a big shift for a lot of organizations thinking more broadly. That is a cultural change that I think has been starting to happen over the last 10 to 15 years, but has a long way to go. CRPs, I think, in some ways are a great way to bring that conversation into the fold, because a lot of what drives the claims and litigation are people feeling like they've been emotionally harmed and the organization didn't respond or treated them disrespectfully or didn't tell them what had happened and make sure they got the support they needed. CRPs are really about proactively addressing that. CRPs hopefully make care safer for the next patient, so the physical harm, the risk of physical harm is lower in the future. But for the patients that have already been injured, they can't change the injury that happened, aside from making sure they get the best care possible. But they can make sure that there isn't that secondary injury by proactively addressing those information and support needs. So hopefully that gets at somewhat what you're talking about. And if I missed it, please feel free to chat in more and I'll try and get back to that. But I don't see any other questions in the chat. So um, I will charge on forward here and let's talk in our last 13 minutes or so about challenges of implementation and how PACT can help. So I have another Slido for you. And this is if you were to think about implementing a CRP in a word, so in just one word, what would be most challenging? Sometimes people might say leadership or engagement or resources or whatever it might be. But for you, what is it that you think would be most challenging to do this work? And you can answer more than once. Feel free to throw in more words if there are multiple challenges that you anticipate, because I think there can be in this work. We recognize that that is a real thing that makes this difficult for folks. But for those that have already implemented a CRP, you've got some real world experience doing this. What was it that was most challenging for you? What is it something that you would want other folks to know about as you do this? I got to see a bunch of folks typing, which is awesome. For those that haven't joined the poll, if you want to, you can scan the QR code. You can also go to the web and enter that 7-digit number and then type in here. But I'm seeing a wide range of things here. So we've got legal as one, consistency, resources, fear in general, standardization, this issue of gaining trust, all of those, I totally agree, I think are really important. Culture, commitment, all really critical things. And I couldn't agree more. I think all of these are true. Different mindsets, bandwidth, all of these. Yeah, really great. And activation. Yeah, these are all of the different things that can come to bear. You know, the way organizations have responded is really pretty embedded in organizational culture and process, and shifting that can be tricky. We know that it can be a really difficult thing to change the way our organizations respond after harm. So thanks for sharing all that. What I want to do is talk a little bit about some of the common implementation challenges we see, and I think this will mirror much of what you just shared, and the ways in which we hope PACT can help you move through those challenges. So one is that cultural resistance. At least a couple folks mentioned that. And really, I think this is a lot about leadership engagement. PACT has a number of different ways to engage your leaders. We're happy to share more about those if you reach out. But really getting your leaders engaged to see how this aligns with things that they already care about, aligns with the clinical and quality mission, why this is a good idea for the organization to take on, so that they can lead the cultural change internally, they can be champions for it, they can model the change themselves. Really, really critical piece, and often the first step to beginning this process improvement. Two, I think, can be the sequencing of work. And, you know, folks mentioned there's training, there's resources, all this that can be challenges in this process. And we certainly recognize that. That's where this sequencing of work becomes really important so that folks don't get overwhelmed and so that when they start to encounter the work, they feel prepared to do it. It's not a surprise. They know what's coming. They've got the tools and resources, skills that they need. We have a Gantt chart and we have coaching. So the Gantt chart, for those that don't know, is a project management tool that helps people sequence the work. It lays out all the big things that need to happen to implement a CRP. What are the big steps we have to have in place? What are the key processes we need to know are working? How do they come together? Which do we really need to have done before we launch? Which are ones that we could work on a little bit afterwards? And we've got coaches, expert coaches who have implemented CRPs or helped run CRPs that can work with organizations to help them. No matter what the problem is that's coming up, here's how you could tackle that. Maybe you could work on this first, and then once you have that, you could work on this second, etc. So coaching can be really valuable. Someone mentioned training, and you know, certainly around training around communication skills is one of the many types of training that can be helpful, and one of the big ones, I think, for many organizations. Figuring out how to train dozens or more of people how to have these conversations can feel pretty daunting. And PACT is really designed to help provide that training and those resources that you need to be able to get up to speed so that you feel people have the confidence and the skills that they need to have effective, high quality conversations. where that and things don't go off the rails if someone says something that they really probably shouldn't have said. The processes and roles, understanding what is the process, how is this supposed to work, what's everybody's role in that process, developing all of that, really important. And of course, that's what we went through today with the process maps. But as we go through it in the PACT Collaborative, we really have a lot of sessions that are dedicated to each key step. So we dive in deeper so that you can get a real strong understanding of what that looks like. And that's, of course, combined with coaching to help support wherever your organization is. Measurement and feedback is a common one. Without the measurement, I think it's often hard for organizations to know how consistent are we. Somebody mentioned that in the word cloud we just did. Consistency is really tricky, but measurement helps make it a lot clearer where the opportunities are to improve consistency and to understand why we're having challenges with consistency. And so we have a measurement guide and tools that help people actually implement measurement. And that's been developed with guidance from organizations that have CRPs, what's been most useful for them, what's most helpful, what's most important as we move forward. And then sustaining, I think sustaining the energy around a CRP. So getting it up and running, implementing it, that's one thing. But consistently using it and sustaining it over time, that's another thing. And that's really where this community of practice and the network of peers come in. So the PACT Leadership and Innovation Network is really this awesome group of organizations and leaders that have been doing this work sometimes for many years, who bring their experience and support to bear to lift everyone up and help do this work better across organizations. And I think that can be a really important piece of things. So that's some of the ways the PACT can help. There are other ways, but I want to highlight the PACT approach, which is really this breakthrough series collaborative structure. Melissa alluded to this, I think, at the beginning, that fosters a community of committed organizations with guidance and support. That's what PACT is about, the PACT Collaborative in particular. It's 6 learning sessions, expert faculty, with 5 action periods in between those. So we start with a learning session, then there's an action period, a learning session, and an action period. It's sort of this dosed response. Rather than giving you all of the things you need to know right up at the front, we spread it out over time so that you get it when you're ready for that part of the process, with coaching in between. And really, by the end of a year, it's a year-long collaborative, this is designed to help you get ready to launch a CRP, so that you can actually have one running by the end of the time. And it's supported by this real suite of tools and resources on this web-based platform for PACT participants. And we've just given you a small taste today of the tools and resources. There's a lot more available to those who are participants. So if you're interested to learn more, there's a PACT info session on September 10th. You can visit that PACT website. There's a PACT info packet with an application, and you can also contact Melissa. So Melissa, I might just open it up. I don't know if you have anything you want to add to this, or things that I missed, something you might phrase a little bit differently, but please chime in.
I don't think you missed a thing. That was great. And I will just say that if anyone is curious about PACT and wants to have a conversation about it and how it might be of use to your organization, I'd be happy to schedule some time to talk. So please reach out anytime. As Lago mentioned, the next wave of PACT will be launching in March. So applications are now open.
Thanks, Melissa. That's great. So I have one more Slido for you, for those that are willing to chat something in here. I'm just really curious, what's something you're going to take away from today's session? What's something that you learned or that was new for you, or kind of provided some insight, or something you're gonna reinforce or do differently, whatever it might be. Just some sense of what you might take away from today. And again, if you have questions, things you kind of want to learn more about, just reach out. Melissa's email's in the chat. I'll share a slide with my email. It's just my first name at uw.edu. But what's something you're going to take away from today? A better understanding. That's great. Thank you. I'm glad. Yeah, and there are lots of tools available to help. I mean, that's really our goal, is to meet you where you are and help you get to the next step, whatever that means for you and your organization. Yeah, this idea of using the process map to create a shared mental model, I think can be really helpful, getting everyone on the same page. That tabletop exercise I described, where you sort of walk through a case, not only can you do that at the beginning of your process, highlighting areas where you think you might need some work to do, But as you get closer to launching, it's another good exercise to repeat a sort of simulation to say, okay, we think we're ready. Let's practice with a recent case. What would this look like now that we think we're ready? Another way to create a good shared mental model among folks. I'm glad you find the maps helpful. That's great. Again, if you have feedback about them, we would love them. Love that and would love to learn from your experience. So thank you for sharing all of that. Really helpful. I'll just leave us here. If there's any questions, I'll hang around for a few minutes. Feel free to chat some things in. Reach out if you have anything to myself or Melissa. But thanks for joining us today. We're real happy that we had this time with you. And yeah, I hope you have a great rest of your day.